All right, guys. This is the lecture over the sinuses. So let me bring up my PowerPoint here. And for some reason, the light keeps on going in and out of my face, so don't let that distract you. So today, again, going over the paranasal sinuses. From what you've learned in your anatomy, there are four sets of sinuses. You have your frontal sinuses located in the frontal bone, maxillary, sphenoid, and ethmoid. This is the routine that we're going to be doing for the sinuses. Now, each of these projections will best visualize a certain sinuses, so I will go over that with you as well. So the routine we're looking at is a lateral PA Caldwell. Now, if you notice with the PA Caldwell, it doesn't say PA axial Caldwell, right? So this one's going to be a little different because we're not going to actually angle the CR. However, we will still keep the 15-degree angle between the CR and the OML. Okay, so we'll do that a different way. So it's a PA Caldwell, not a PA axial Caldwell. Then we'll do a Waters projection. And there are two special projections, the SMV and the open mouth Waters, also known as the parietal-canthial transoral. So these are the 5 projections of the sinuses. Now, a lot of these we've done before, right? The lateral, Caldwell, Waters, and the SMV. So the real new one is the open mouth Waters, and it's exactly what it sounds like. You do a Waters position, and then you just open your mouth. So we'll go over that. All right, so some technical considerations to kind of understand before you start the sinuses procedure. KV range for all of these projections will be somewhere between 75 to 85. So again, if you use about an 80 kVp, you should be within the range of each of these projections. Sometimes most of the time we prefer to do the sinus projections erect because again, when we're doing sinuses, we're looking for mucus in the sinuses, right? So we want to see that air fluid level. The book does recommend that in order to demonstrate air fluid levels within the sinuses, we should probably keep the patient upright, either sitting upright or standing upright for at least 5 minutes before doing the projections to let everything kind of settle to the bottom. Obviously, we don't do that. Most of the time, we just get them in and out. So sometimes the air fluid levels is not accurate whenever we don't let them sit for about 5 minutes. Again, when you're trying to look at a air fluid level, you want to use a horizontal beam. Okay, so no angle of the CR. All right, and then also for most of these projections, AEC is not recommended because again, if you have excess fluid in there, it's going to mess with the AEC system, and it's going to give you a technique that's probably not good, probably too much technique. So a lot of these you want to try to use a manual technique, and I always suggest to the students that when you're at the site and they happen to use AEC for certain projections, the AEC will give you a readout of the mass that was used that was enough or appropriate for that exam. Pay attention to the readouts. That way you kind of have an idea about a range of what to use for each exam that you do, okay? All right, here's the first one we're doing. Now, if you notice, it says left or right lateral position of the sinuses, because again, this is dependent on where the I guess the pathology or the injury would be. So if there's more sinus pressure on the left, you can do a left one. If there's more sinus pressure on the right, do a right. But majority of the time we do a left lateral position as the standard for sinuses. KVP 75 to 85, 40-inch SID. All right, now again, erect is the best position to have the patient in. So you should do all these sinus projections erect. Again, because we're trying to see air fluid levels. Have the patient face in the IR, and then you're going to have them turn their head to the side and kind of get them in a true lateral position, right? So we know all the criteria for a true lateral position. Get that mid-sagittal plane parallel to the IR. Make sure the IPL is perpendicular to the IR. The IOML is perpendicular to the front edge of the IR. And then, of course, the GAL is parallel to the front edge of the IR. Make sure there's no rotation or tilt, okay? So nothing too tricky about this one, right? You still get them in a lateral position like we've done for all lateral positions. We want to make sure the CR is horizontal, no angle of the CR, and it's perpendicular to the IR. We're going to center midway between the outer canthus and the EAM, all right? So find that point midway between the outer canthus and the EAM. So if we look here, right, there's the outer canthus. There's the outer canthus. Here's the EAM. We're going to find a point somewhere in between there, and that's where we want to center, okay? Now, once you've done that, collimate to the area of interest and suspend respiration. Okay. Now, what I can tell you is that this projection, all right, is kind of the best to see all four sinuses at once. Okay. So it does give you a lateral view of all four sinuses at once: maxillary, the sphenoid, the ethmoid, and the frontal. Okay. So once you've done that, column A, suspend respiration. Okay. And you can follow along. This projection is on page 437. All right. Now, it does say C notes at the bottom, right? So if you look in your textbook towards the bottom where the notes are, it does talk about the 5 minutes of the patient having the patient stand up for 5 minutes or sit upright for 5 minutes to allow all of the fluid to collect to the bottom of the sinus. So that's the best way to get these lateral positions. Right? All right, so let's look at the lateral and what it should look like. Or again, we're looking for all four sinuses to be demonstrated. Okay, so if we look here, all right, there's the frontal. All right, here's that big maxillary sinus. Here is the ethmoid sinus, and then these are I'm sorry, this one is the sphenoid sinus. I'll put an S for sphenoid. This one is the ethmoid. This one is the frontal, and this one is the maxillary. Okay. So again, we can see all four sinuses demonstrated, right? And we didn't clip off any of them. So make sure you get from the frontal sinus down to the maxillary sinuses. And then from the EAM is usually where you want to column A2 to the front of the face, okay? So again, sphenoid, ethmoid, frontal, and maxillary sinuses. Now, you can always kind of tell where the sphenoid sinus is because it's located right underneath the sella turcica, right? So we see here, there's that sella turcica, right? That kind of saddle. And then underneath here would be where the sphenoid sinus is, all that dark space. All right. Ethmoid sinuses, you're going to have a few of them, so that's why there's a couple of them there. All right. Big old maxillary sinus here, and then your frontal sinus is there. Okay, so make sure all are demonstrated. Make sure the cranium is not rotated or tilted, right? So how do we look for rotation for a lateral position? What kind of separation are we looking for? We're looking for anterior posterior separation, right? And the first structure you should look for on a lateral is the mandibular rami, right? So if you see one line there, there's no rotation, okay? What about for tilt? What's the first structure we should look at? Should be the orbital plates or orbital roofs, right? And we're looking for any type of superior inferior separation. If you do see that, then you have tilt, okay? But those two structures should be the first you look at. And of course, you can look at the EAM, sella turcica, and then this is a good projection of the greater wings of the sphenoid. See how you have one up here, one right there. Okay, so you got a little bit of rotation there. Okay, and then of course, optimal exposure factors, sharp lines, bony trabecular markings, right? But important thing is that this one is used for all four sinuses to be demonstrated. And that's supposed to be a star. There we go. It's better. All right. So the next projection is the Caldwell projection. Now, again, it doesn't say PA axial projection. It just says PA projection. That's because this one does not have an angle of the CR. Okay, so what we're doing is we're angling the OML as opposed to angling the CR, okay, to get that 15-degree angle. So this one here, I can tell you it is best to visual, or it is used to best visualize the frontal sinus. Okay, so frontal sinus, make a note of that. KVP 75 to 85, 40-inch SID. Again, get them in the erect position. Put them up against the image receptor, right? And first thing we're going to do is rest the nose and forehead on the image receptor, right? So put the nose and forehead up on the image receptor. Then what you're going to do is you're going to slightly extend the head to bring the AML perpendicular to the image receptor. Okay. So normally, I'm sorry, not the AML, to bring the OML 15 degrees from horizontal. Okay. So to kind of judge that, usually if you kind of put the tip of the nose on the image receptor, right? So we have the nose and forehead on there. And if you put the tip of the nose on there, that should bring the OML up enough to give you that 15-degree angle between the OML and the CR. Okay. So again, it's not the AML exactly. It's more just kind of lift up that, extend that neck, kind of bring that nose on the image receptor and get that OML up 15 degrees from the CR. Okay, so what I mean by that is if you look here, right, if my CR was coming straight, it'd be about right there, right? But the OML you see goes up this way. So that angle there is about 15 degrees. Okay. So what they did is they extended the head, right, and brought that nose onto the tip of the nose onto the image receptor, and that raises the OML 15 degrees from the CR, which still creates the Caldwell projection because we have the 15-degree angle between the CR and the OML. Okay. Make sure there's no rotation or tilt of the head. The CR should always be horizontal or parallel with the floor. So we don't want any CR angle in order to, just so we can get good air fluid levels. We're going to center the exit at the nasion, all right, collimate and suspend respiration. Okay. Now the book does talk about an alternative method, which is this one here. Okay. So it's saying that if you have an imaging device that tilts, like you see here, this imaging device is tilting, then you can go ahead and tilt the device to match the nose and forehead while you're still keeping that CR perpendicular. Okay. This one will actually give you the better projection because now we have the part parallel to the image receptor. Okay. Most places don't have that device, so most of the time you're going to do it like this one here. Okay. So important thing to remember on this one is that we are not going to angle the CR 15 degrees, right? We're going to instead elevate the head or raise the chin up to bring the nose onto the image receptor or to bring that OML 15 degrees from horizontal. So again, here's your horizontal. We extended the head and brought that OML up 15 degrees from the CR. All right. Again, this projection is best to visualize or used to best visualize the frontal sinus. All right, here it is. So the frontal sinus is what's best visualized, okay? But you can also see the ethmoid sinuses. So here are the frontal sinuses. All of this, you can kind of see the outline going like that, right? All that is the frontal sinus, right? The ethmoid sinuses are down in here, okay? So all those structures that you see in there, those are the ethmoid sinuses, all right? Now, it's not the best projection for the ethmoid sinuses, but again, you can visualize it. But this projection is best used for the frontal sinuses. Okay, we still want to make sure it's a good Caldwell projection. So just like any other Caldwell we had, what do we look for on the radiograph? Right. Well, we're going to look for the position of the petrous ridges, right? And here they are. And those ridges should be in the lower 1/3 of the orbit. Okay. So you see here, they're a little low, right? Here's the lower 1/3. Right, we broke this down to 3 spots. There's the first third, second third, lower third. All right, so those ridges are a little low. Now, if you see them a little low like that, again, it tells you that the angle between the CR and the OML was over 15 degrees. Okay, so either you need to decrease the extension a little bit, right? Either you extended too much, and that's really the only way that this would happen is if you had the head extended too much, because we're not angling the CR, we're keeping it perpendicular. Make sure there's no rotation or tilt. Right, rotation, we check from the lateral orbital margins to the lateral cranial cortex on each side. If it's the same, no rotation. Tilt, we're just going to use the mid-sagittal plane, which comes down this way. If it goes this way or this way, then we have some tilt. All right. Optimal exposure factors, sharp lines, bony trabecular markings. All right, so again, sinuses, right? For the Caldwell, important thing to remember, we're not angling the CR. What are we doing to get that 15-degree rotation between the OML and the CR? Well, we're going to elevate the head, right? Extend the head, bring the chin up to bring that OML 15 degrees from the CR, okay, or from horizontal. When we look at the radiograph, we want to make sure that we see the frontal sinuses demonstrated because this projection is best used for that. Also, we want to make sure that the ridges are in the lower 1/3 of the orbit because that is a good Caldwell projection, right? What other sinuses can be visualized on here? The ethmoid sinuses. Okay. All right. Moving on. Next one is the parietal waters projection. So this projection is best used for guess which sinus, right? I mean, what are we always looking at? The maxillary sinuses. So this projection here is best used to visualize the maxillary sinuses. It also does give you an oblique view of the frontal sinuses, okay? An oblique view of the frontal sinuses. So KVP 75 to 85, still 40-inch SID, put them in the erect position to get that air fluid level. We're going to extend the neck again, put the MML perpendicular, right, which means you're going to rest the chin on the image receptor and bring that MML perpendicular to the image receptor, okay? Now, again, what angle is formed between the CR and the OML? right? So if we look here, I'm sorry, between the IR and the OML, it is at 37-degree angle. Remember, that's important because it helps to put the ridges below the maxillary sinuses. Okay, make sure there's no rotation or tilt. All right, collimate, suspend respiration. Okay, you're going to center the exit at the acanthion on this projection. Okay, so nothing's changed on this water's projection. All we're doing is we're going to visualize a different structure, which is the maxillary sinus. So important things to remember for the water's projection. What position line is perpendicular to the image receptor? MML. What angle is formed between the OML and the IR? 37 degrees. Why is that important? It helps to put the maxillary, the Peters ridges below the maxillary sinuses, okay? Here's what it looks like. So we do see the maxillary sinuses demonstrate, I'm sorry, that's the frontal, sorry. See the maxillary sinuses demonstrated, all right? Again, I told you it does give you an oblique view of the frontal sinus, not best for the frontal, right? Again, the best view for, or best projection for the frontal sinuses is the PA Caldwell. This projection is best used for those maxillary sinuses, okay? Now, if you notice here, right, here's the sinus and then here's the bottom, right? And they're supposed to have kind of like a rounded bottom there. This one here, you can't really see the bottom over here, right? Because it's kind of got all this junk in there. That is fluid, right? Or mucus from the inside the sinus. So this left sinus does have some fluid within the maxillary sinus, okay? The Peters ridges are actually down here, right? So they're below the maxillary sinuses, which is what we want, all right? Remember, if you see the ridges within the maxillary sinuses, that means that you did not extend enough. Your head was too much flexed, okay? Which means you didn't bring that MML perpendicular. We want to make sure there's no rotation, right? So we check again the lateral orbital margin to the lateral cranial cortex. If it's the same on each side, then there's no rotation, okay? If one side gets bigger, right? So if the left side got bigger, then the face was rotated towards the right. Tilt, we just check that mid-sagittal line, again, if there's any tilt. We want to make sure we have optimal exposure factors, sharp lines, bony trabecular markings. Okay. Now, the one thing about this projection is that the sphenoid sinus is located right in this area, right? But what are those structures there that are blocking it? Those are the teeth, right? So when we have the mouth closed, you can't see the sphenoid sinus. So remember I told you we have a new projection called the parieto-acanthial transoral, which means that it's going through the mouth. So again, we are going to do that transoral projection to view the sphenoid sinus through the oral cavity. Okay. Important things for this one. What sinuses does it best visualize? Maxillary sinuses. It does give you an oblique view of the frontal sinus, right? So that is another sinus that can be viewed on this projection. Okay. Where should the ridges be in relation to the maxillary sinuses? Should be below. Okay. What happens if you see them in the maxillary sinuses? That means you weren't extended enough, right? You had too much flexion, okay? This time we're not going to deal with angle on this one for the sinuses because the CR angle should be perpendicular, okay? All right. Here's the SMV projection. All right, so now we are on page 440, all right? So this SMV projection we've done before, right? We did it for the skull. This projection will best visualize the sphenoid and ethmoid sinuses. Or this is the sinuses that you'll be able to visualize on here would be the sphenoid, the ethmoid, a little bit of the maxillary, okay? The KVP is 80 to 90, 40-inch SID. So if you notice, this KVP does go a little bit above the range that we talked about, the 75 to 85. So this is the one that goes from 80 to 90. All the other projections will be from 75 to 85. You'll do the position erect, either standing or sitting, right? Sometimes you can use a wheelchair to kind of have them lean that head back, because when we are positioning this patient, we want to try to get that vertex of the skull on the image receptor, okay? So we're going to raise the chin, right? Hyperextend that neck, bring that IOML parallel to the image receptor. Here's the IOML, should be parallel to the image receptor, all right? You're going to rest that vertex on there, make sure that there's no rotation, no tilt, okay? And we're going to have the CR again horizontal, and it needs to be perpendicular to the IOML. Okay, we're going to center midway between the mandibular angles, or 1.5 to 2 inches inferior to the mandibular symphysis, right? So again, let's see. I haven't used this one today, so we'll use it. isolate the skull. There we go. All right, so SMV projection, right? So again, we want to make sure that we have the head extended, right? Bring the IOML parallel to the image receptor, okay? Now, again, what we're going to center is midway between the angles, okay? So we're going to go either midway between there or 1.5 to 2 inches below the mandibular surfaces, which should get you at the same point, okay? Now, remember, if you see these condyles, which are located here, right? If you see those condyles within the mastoid portion, then that means that your head was too flexed, right? You didn't have enough extension, right? Or the CR was not perpendicular to the IOML, right? You also want to make sure you see that the teeth are superimposed over the frontal bone, okay? If you do see the frontal bone above the teeth, that means, again, did not have enough extension, you had excessive flexion, or the CR was not perpendicular to the IOML, okay? We'll go back to the PowerPoint. All right, now, once you've done that, collimate, suspend respiration. We want to make sure that we make sure you get to at least to the outer edges of the face so that we don't clip off anything. Suspend respiration. And again, do this one pretty quickly because it is uncomfortable for the patient. Here's what the SMB looks like. So we want to make sure that we see the sinuses that we're trying to visualize. We are trying to look at the sphenoid and the mastoid, not mastoid, the sphenoid and the ethmoid sinuses here. So if we notice, the ethmoid sinuses are going to be right in this area here, right? So you kind of see them there, like little dark areas. Those are the ethmoid sinuses, all right? Now the sphenoid sinus is a little bit, make sure I'm on the right page here. Yep. The sphenoid sinus is a little bit trickier to see. It is located down here. Okay, so that area right in there is a sphenoid sinus. And then you have your maxillary sinuses over here, kind of superimposed by the teeth. So this projection is best used to visualize the ethmoid and the sphenoid, right? Maxillary are a little bit harder to see. Right? Make sure there's no rotation, no tilt. So again, for tilt, we want to look at the distance between the lateral or the ramus into the lateral cranial cortex. If it's the same on each side, then you have no tilt. Rotation, we just look for the mid-sagittal plane, right? If it goes that way or that way, then you have rotation, right? But the tilt is when you have one side greater than the other here, okay? Make sure that the condyles are not superimposed over the mastoid. So here's your condyle, right? And you see that one there. The other one's a little bit harder to see. It's pretty tricky. Looks like it's right here. But we want to make sure that that's free of any superimposition of the mastoids there. If you do see the condyle superimposed over the mastoids, it did not have enough extension. It was too much flexion. Okay. And again, optimal exposure factors, sharp lines, bony trabecular markings. All right. So important thing for the SMV, what sinuses are we looking at? We're looking at the sphenoid, the ethmoid, right? And you can see a little bit of the maxillary sinus, but it is best for the sphenoid and the ethmoid. Okay. We want to make sure that the IOML is parallel with the image receptor. Make sure our CR is perpendicular with the IOML. Okay. All right, the last projection we're going to learn, which is the new one, is the parietal-canthal transoral sinus, or the open mouth waters. Okay, this projection is best used to visualize the sphenoid sinus through the mouth, right, or through the oral cavity. KVP 75 to 85, 40-inch SID. Again, put them in the erect position. We're going to start them off by putting the patient in the waters position, which is to raise the chin, put it on the image receptor, and get what position line perpendicular? MML. And that helps to form one angle between the between the IR and the OML, 37 degrees. Okay, once you've done that, now what you're going to simply do is have the patient drop the jaw. Okay, don't move the head, just drop the jaw. Excuse me. Oh, excuse me. So again, have the patient lift the chin, right? And all they're going to do is just drop the jaw. Okay, so no need to bring the head down or move the head. You keep it in with the MML perpendicular, right? And then all you're going to do is just drop the jaw. Okay. Now, when you do that, the MML is no longer perpendicular because the jaw has dropped. But you'll get the head in the good position first to get that 37 degree between the OML and the IR, and then we'll drop the mouth to open up that oral cavity to see the sphenoid sinus through it. Okay. CR is horizontal, perpendicular to the IR, and you're still going to exit at the acanthion. All right, collimate to the area of interest and suspend respiration. Here's what it looks like. Okay, and what we're looking at right in there, sphenoid sinus. Okay, we can see it right through the oral cavity. Make sure there's no superimposition of the teeth. If you do see the teeth superimposed, that means that you were too much flexed, you didn't have enough extension. Okay, we still want to make sure that the ridges, which are down here, there's a ridge line, are below the maxillary sinuses, which they are. Okay, because we still want to be able to visualize the maxillary sinuses, and we still get an oblique view of the frontal sinus. Okay. But this transoral projection is primarily used to visualize the sphenoid sinus through the oral cavity. Okay. Make sure there's no rotation, no tilt. We want to make sure we have optimal exposure factors, sharp lines, bony trabecular markings. All right. So, important thing. This transoral waters is very, very similar to the regular waters. The only thing we're doing is once we get the patient positions, we're going to drop the jaw, right? Other than that, everything else is the same. Centering point, the OML, the degree of angle between the OML and the IR, all that is the same. What we should see on a radiograph as far as where the ridges are in relation to the maxillary sinuses, the oblique view of the frontal sinus. But now we're able to visualize the sphenoid sinus through the oral cavity. Okay. All right, guys. Well, those are the 5 projections for the sinuses. I know went through it pretty quick, but a lot of this stuff you already knew, right? So just kind of a review. Hopefully, it was just a review. If you have any questions, make sure you email me. Make sure you ask me in lab. But that is the lecture for the sinuses. Right now, we're going to go into some critique of some radiographs for the sinuses, just so you can kind of get a better understanding of when there's a bad radiograph, what it looks like. So let's look at these first. All right, open mouth waters. Which radiograph demonstrates a repeatable error, A or B? Okay. So again, this is the parietal transoral. So we're looking at to be able to visualize the sphenoid sinus through the oral cavity. Okay. So which one is the error one? Right. Hopefully it's pretty obvious. Right. And 3, 2, 1. Hopefully you said A. Right. A is the bad one. Okay. So since we know A is the bad one, right? What is the error? Right. So we're gonna answer the second part. What is the error? Okay. Well, let's look at it. So we know it's a waters projection, right? So what should we look for in order to determine if we have a good waters projection? All right. Well, hopefully you said that the ridges should be below the maxillary sinuses, right? Well, here are the maxillary sinuses, and here is your petrous ridge, right? This whole structure there is a petrous pyramid. Here's your maxillary sinus, there's the ridge, and that whole thing is the petrous pyramid. They are located within the sinuses, like right smack in the middle of the sinuses. So obviously, what does that tell you when you have the ridges within the sinuses, right? Well, that means that your head was flexed too much, right? You need to extend the head to bring those ridges below the maxillary sinuses. So by seeing that, the sphenoid sinus should be located somewhere right in here, but we're going to have it superimposed by the teeth. Again, because we have too much flexion. Here is the back of the head, the back of the skull, the occipital bone, right? That should not even be visualized if you have a correctly positioned waters, right? That should be much, much lower because we would extend our head, okay? But because you can see it now, that means you have too much flexion. Okay, so that's one error, right? We didn't extend the head enough, too much flexion. What's another error? Obviously no marker, right? And then if you look here, right, the mid-sagittal plane, we have a little bit of tilt, right? You see how it's kind of going that way a little bit? So we got a little bit of tilt on there. All right, so let's see what the errors are. Right, insufficient extension, right, which means that there was you didn't have the head extended enough, no marker, and then of course the sphenoid is not demonstrated, right, because the sphenoid would have been about right there. Okay, but we have the teeth superimposing. So let's look at the waters projection here. What are the 2 repeatable errors present in radiograph B? So I'm not even going to ask you which is the bad radiograph, right, because obviously it is B. All right, that thing looks messed up. It's supposed to be a waters projection. So what errors do you see here compared to the first one, compared to A? Okay, well, first thing we should see is the ridges, right, which are those there below the maxillary sinuses. Okay, do we see that over here on this one? Well, here is the ridge there, and there's the top of the maxillary sinus, right? So the maxillary sinus is there, but there's the ridge and there's the petrous pyramid. So again, the ridges are within the middle of those maxillary sinuses. So what does that tell you? Right, do your whole hand thing, right? They're down here, right? Hopefully you can see me. The light's kind of messed up in here, right? But here, if they're too low, right, then that means that you had your head flexed too much. So we need to extend the head to bring the ridges below the maxillary sinuses. So there's not enough extension there, right? All right, what else is wrong? Right, if you said no marker, you are correct because there's always no marker on there, right? But what else do you notice, right? So let's look at the distance between the orbital margin, lateral orbital margin, and the lateral cranial cortex, right? Well, we have one side that's very, very big compared to the other, right? Again, if one side is bigger than the other, then you have some rotation, right? And the rotation was to the left side. Okay, you see how the face is going that way. All right. So if you said these structures here, as far as being like artifacts, they aren't. They're hardware to keep the skull in place. So what they did is they kind of cut open pieces of the skull, either to relieve pressure or to do some type of surgery in there, and then to suture it back up, they use those metal hardware to keep the skull pieces in place. If you notice, there's like a line there, right? That's a tube, right? That tube is usually used to kind of help relieve pressure, maybe drain some fluid in the head. It's like a shunt to help take fluid out of the head. Okay, but the main errors were there's no marker. Well, the main error is that it's underextended, right? There's not enough extension. It's rotated and there's no marker. Okay, that's what we got here. Rotated, underextended, no marker. Very good. All right, SMV projection. Identify 3 repeatable errors present in this radiograph. Okay, so SMV again, what criteria should we be able to, or what criteria can we use to help determine if we have a good SMV? Right, well, SMV, of course, you need to make sure you have a good extension, right, to bring that, bring those teeth superimposed over the frontal bone to make sure that the condyle is not superimposed by the mastoids, right? But if we look here, see this little kind of like oval structure right there? I'm going to draw it and then I'll erase it. That oval structure is the condyle, right? And the other one is over here. All right. Now you see all of this stuff here, right? Kind of look like dark little areas like bubbles in there. That is your mastoid area. So we have the condyles superimposed over the mastoids. So what does that mean? Again, let me go back to this guy here. All right, and I'll enlarge it a little bit. So here are the condyles. Condyle there, condyle there. Here's the mastoid area, okay? So what happens when you see those condyles superimposed over the mastoids, right? You did not have enough extension. It was flexed too much, and that's what happened there, okay? So first thing there is we have not enough extension, right? We have too much flexion going on. Also, we want to make sure we check the tilt, right? Rotation and tilt. So rotation, we're checking the mid-sagittal plane, right? So if you notice, it's kind of going that way a little bit, right? So we have a little bit of rotation. All right, now let's look at tilt. Tilt, we're going to check the distance between the ramus to the lateral cranial cortex, right? There's a ramus there, so the lateral cranial cortex is way over there. So we have a little bit of tilt as well. Okay, so not only do you have rotation, you have tilt, right? No marker, right? What else? All right, well, notice all the space we have here, right? But we're kind of clipping stuff off over here. Okay, so again, we have a centering problem there. It's not centered up to the image receptor, and so we're kind of clipping off some things there. Also, if you notice, right, all this right here, so they did do some extra collimation, probably maybe too much collimation, so you're kind of clipping off some of the anatomy there. So let's see what the errors we had. Tilt, rotation, underextended, and then we have the centering problem, right, marker. So we would have moved it over a little bit to the left over here, right? If we would have moved it over this way, we probably would have been able to get all the other structures that it clipped off over here, okay? All right, here's a lateral projection. Identify the position errors present in this radiograph. Okay, so I'll give you a few seconds here to look at it. In 3, 2, 1. All right, so what are the first things we look for when we're doing a lateral, right? We want to make sure, of course, first, all the anatomy is there. Okay, so if we're doing sinuses, right? Here's the frontal sinus. We got that on there. There's the maxillary, right? Here is the sphenoid sinus, and then there are your ethmoid sinuses. So we got all the sinuses on there, right? So all the anatomy is there. But we're also looking for rotation and tilt, right? So what's the first structure we're going to look for tilt? All right, so hopefully you said the orbital roof orbital plates, which are these right there, right? And what do you notice? One line there, one line there. So we have some major tilt going on, right? We have superior inferior separation. What other structure can we use to determine rotation? Okay, so rotation, we're going to look for the mandibular rami, which are down here. Notice you see one line there and then one line in the back. So again, 2 lines means that there's anterior posterior separation, which means you have some rotation. Okay. The other things you can look for again are the EAM, Celaturcica, greater wings. A little bit harder to see on here, especially the EAM because it's kind of somewhere in there, still superimposed over the mastoids. Celaturcica is not a very good Celaturcica, but it is right there. Okay. And then the greater wings would be those 2 structures there. All right. So again, with this, we have some errors there, right? Especially with the rotation and tilt. Also, if you take a good look at it, right? Right in here, kind of looks a little grainy, right? Maybe a little grainy in here too. So when you see it's grainy, what does that tell you? Right? That tells you that you have a problem with exposure, okay? So we have tilt, slight rotation, and we have an exposure problem, okay? All right, so let's look at this one. What is the angle between the OML and the plane of the IR for a well-positioned parieto-canthal projection? I mean, that should be quick, right? You shouldn't even have to think about that. Again, the angle between the OML and the IR on a regular parieto-canthalar waters is 37 degrees, okay? What if it's the angle between the OML and the IR for a well-positioned modified parieto-canthal? Right, again, boom, you should know it is 55. Okay, so again, those angles, very important because if it's 37 degrees, then that makes sure that helps us to know that the ridges will be below the maxillary sinuses. If it's 55 degrees, then we're going to know that they're going to be in the lower half of the maxillary sinuses. Okay. Which sinus is best visualized on a well-positioned Caldwell projection? All right, so again, the key word here is best visualized. Which sinus is best visualized? Right, it will be the frontal sinus. Now you do see the ethmoid sinus, right? But that is not going to be best visualized, right? The best visualized sinus is the frontal sinus. Okay. What sinus is best visualized on a well-positioned waters projection? All right. So if you said, well, I'm not going to let you answer. 3, 2, 1. Hopefully you said the maxillary sinuses. That is what's best visualized on a well-positioned waters. Now, can we see the frontal? Yes, but it's an oblique. Can we see the sphenoid? Not really, because it's superimposed by the mouth, right? And the ethmoid we don't see at all, okay? So the best projection there would be the maxillary. Now, if I did ask you which sinuses are visualized on a well-positioned waters, then we would say maxillary and frontal, okay? But if I asked you on a frontal, I'm sorry, on a Caldwell, then you would say frontal, you would say ethmoid because you'd be able to see that, right? So what about lateral? All right, so think about it. On lateral, which sinuses can be seen? Right, all 4 of them. Okay. Now, which sinus is best visualized on a well-positioned open mouth waters projection? Right. Now, for what is this projection used for? Right, it's used to see the sphenoid sinus. All right, transoral open mouth waters. That's what it's used for. Now, what other sinuses can be seen on there? Maxillary and frontal. Okay. So you can see how this can turn into a 1, 2, 3 question, right? It can be like, which of the following are visualized on an open mouth waters projection, right? And if I put 1, 2, 3, maxillary frontal sphenoid, then you know it's going to be all 3, okay? But if it says which is best visualized on this open mouth waters, then we know that it's the sphenoid because that's what we're using it for. Okay. All right, guys. Hopefully that wasn't too bad. Should have been kind of like a review. Make sure you go back over this lecture, kind of review anything you need to for this. If you have any questions, you can email me or, talk to me in lab when we're in there. Um, but this week coming up is our last week in the lab in person. So we'll kind of finish up what we need to finish up in there, and then the rest of the classes will be online via Zoom. All right, guys. Well, that's all I have for you. If you have any questions, again, contact me. Let me know. I will see you next week. Thank you.